Hey guys, welcome back to the FOAMfrat podcast. We got a different kind of episode for you guys this time. Tim Redding, he's been a friend of ours for a while, reached out and he introduced me to Dr. Alyson McGregor. And she has a particular topic she's very passionate about, has been passionate about it for a long time, and she's also an ER physician. She's in South Carolina now. And so he said, you guys got to have her on the podcast. We got to talk about this because she's found some pretty big discrepancies between men and women, diagnostic treatments, medications we give. And so the conversation definitely did not disappoint. It was fantastic. It made me want to do more research into this. And so I sent it over to Sam to listen to so we could record an intro. And then he had some interesting thoughts on it as well. So I thought before we get into that, let's just discuss some of those.
Yeah, well, the first thing that it made me think of was just the actual coronary occlusion cases that I've seen in females, and like the memorable ones were more atypical, I guess. I put atypical, I guess.
Can't say that.
Air quotes. Yeah, in air quotes now. And like I remember one with an RCA occlusion, and it was like sinus arrhythmia was the only thing that was showing up, or like this LAD that I had, and it was like one bout of diarrhea and then lethargy, and that was it. And I thought in my head, good for me. I caught the atypical stuff, but now I'm like starting to realize, well, it's just atypical for females because we consider those classic symptoms based off of a cohort of mostly males. And so maybe it's not so atypical. But so that was one direction that it took me in. But where my brain really went with this, and you won't be surprised, but I started thinking about like AI and statistics and stuff. But I'm doing this pediatric class. Actually, I just finished it up, and I was doing these developmental cycles for them. So at this age range, here's like their 99th percentile versus their first percentile for just basic things like heart rate, respiratory rate, blood pressure, just big averages. And we don't account for much of that. Like, it made me realize that we're just really taking this narrow field of averages and we're just kind of pretending that that is for everybody. I guess, we do a little bit of it. If you look at the ECG, you type in like the age and you type in the sex, and that should get you a better 12 lead because it's like putting it through filters, And then on the vent, you might put in like height. And so it's like a little bit of personalization. But I think in the future, that's where my brain went with this, like the future, like how do you actually take all of these different sets of data, and instead of just having to like sort through them and filter through them on your own, because now it's like, are we going to teach a separate class on males versus female ACS, or there's going to be a special section in there, like these are their classic symptoms, these are their classic symptoms over here. And I think we're seeing a little bit of this like data aggregation in AI charting, like Colby is really into, like AI data charting and stuff like that. And what that is doing is it's taking all that data that it hears, and it's saying, here's the age, here's the height, the sex, all these different things. It can take your vital signs and stuff, but it's not giving anything back to you. And so I think the next stage in that is like real-time data aggregation. It's going to take all those things, your age, height, sex. It's going to listen to like the acute medical history versus the chronic medical history, and it's going to weigh that all against your vitals, and it's going to help inform care. I think it's actually going to be like a prospective thing that we think about, which is really interesting. But there's like that funny saying, people say like, oh, the patient didn't read the book, and they'll say that when somebody didn't exactly like fit this mental model that they have. But it's like the patient isn't a book. It's like everybody's very unique, they're a complex organism, and they're difficult to standardize. And it turns out, especially as you guys will here in the podcast, when you mix male and female data.
So the topic today is a mission that you have been on, Dr. McGregor, since it sounds like as soon as you finished residency around 2007, I think is what we just calculated.
Right.
What is that mission? What was your eye-opening moment where you said, this is something I need to get out? I need to start talking to people about this.
Yeah, it's really interesting because I think it's similar to EMS. We are trained to look for pattern recognition, right? So what does it look like if you are having a heart attack, if your patient's having a heart attack? What does a stroke look like? What are the vital signs that you look for if you want to think of sepsis? And these are things that take a while, and it's part of our educational process, and we've sort of really, really earned that. And so throughout my emergency medicine residency, which was 4 years of really, learning how to find pattern recognition, once I, started practicing on my own, I was started to see different types of patterns. I saw patterns of bias, really, specifically towards women. So many women were not being diagnosed with a particular condition, or misdiagnosed, or were often diagnosed with things like anxiety disorder, because when they came in with their symptoms, they didn't fit into any of the patterns that we were so ingrained and taught. So what we were supposed to do. We just said it was supratentorial. It was something psychiatric. It was anxiety, something that we couldn't see with a CAT scan or learn. So with that, I started to really look into why that was the case. Around that same time, the cardiologists, that sort of cardiovascular area, they were the first people to say that women might present differently with a common condition, a heart attack. And they used the term atypical. So women present atypically. And I thought, well, why? So I started to look into the literature and realized that it's because women have a different way of having a heart attack. They have slightly different anatomy, different physiology, different way of sensing those symptoms. So that took me down a rabbit hole because I realized that most of our understanding of research and medicine and science has been based on this assumption that men and women were basically alike, were the same outside of reproductive organs. And so that to me was really, an eye opener. And then I started to think, well, of course, just like EMS, just like emergency medicine, we get to see the entire spectrum of human health and disease. Right. So if it happens, we see it. It's really, it's a remarkable viewpoint of society. So then I started to notice that in different elements, like in stroke and presentation, and and why is it that we always assume that women are having women with chest pain, it's either like why we're always saying it's indigestion or if it's psychiatric. So that's how I really started to dive deep and just found this area completely fascinating.
And so you're in your residency here and you got all that, physiology, pathophysiology, biochem, like fresh up here. You're taking all these tests and you're trying to figure this out. And I've heard you refer to, you go back to, what was it, World War II, when they were doing a lot of the testing. And they were not including women in this testing because they thought they were protecting them, right? They were doing it because you start testing someone and then you realize, oh, no, she's pregnant. And then it's like, well, who's going to be responsible for this, right? So is that kind of where you trace that back to, as when we started testing primarily on men, besides the fact of, men don't have different hormone cycles throughout the month and things like that. Is that really where that this started, do you think?
That's exactly right. When we started doing the scientific method, when we started, really sort of embracing what evidence-based medicine is, we're supposed to really sort of do an experiment, find evidence, and then use that and translate that into practice. That was happening around the time that World War II is really where, it's studied enslaved individuals all over the world, even in the United States. And so that was really horrific, right? So we needed something to create rules around. And that was also the time that there were a lot of, thalidomide and conditions where women who would become pregnant during a study and have some sort of teratogenic effect. So around, the National Research Act, 1973, was very important because it established rules for informed consent, right? So you have to really, have informed consent. You have to have a conversation about what you know. You have to have human subject protection. You have to go through an institutional review board. So we created all of these rules meant to protect vulnerable individuals. But at that time, women were classified as a vulnerable individual. And again, like I said, the basis was we thought it was okay because we thought, if we just studied men and we apply that to women, that would be okay. So that's when we really ramped up. That's when we had the physician's health study, when we understood what coronary artery disease is. That was, enrolled 22,000 men. And that became our understanding. And so the only thing we couldn't study in men was having babies and menopause and the menstrual cycle. So then we studied those things in women, and that became equivalent to what women's health is, simply just reproductive organs. And so that was the main sort of, split. And I always like to keep in mind that this was not, conscious. This was done by both women and men's, scientists and researchers. And this is just the evolution of our understanding of human health. And it's humbling. And so now, we're evolving.
And I'm glad you said that. Like, it wasn't a nefarious plan.
Right.
Like, okay, we're going to get all these meds approved, and then we're going to have these bad effects on women. So no, fascinating. What I want to do is I'm kind of stopping your journey there, and I kick it over to Tim for a second. So Tim, you posted on social media that you were working on a new presentation. What was it called? Sex Matters, I believe, right?
Yeah, Sex Matters. It's named after Alyson's book, and I've changed a couple of the after Sex Matters a couple times. I think now it's Sex Matters. How our care may be harming our female patients, so something around that. And so Allison's book came out around 2020, and I bought it right away to support Allison. And it was about maybe 8 months later that I read it, kind of during COVID 2021. And as most instructors that you talk to, a lot of your motivation for a class, you'll hear a quote, you'll hear a line in a song, you'll read a book or something like that and say, I can make a lecture out of that. And as soon as I read Allison's book, my thought was EMS people need to hear this because we're assessing male and female patients. And so I listened to the audio book again. So read the book and listened to the audio book and reached out and said, hey, can I make this an EMS lecture for conferences and local stuff? And she was super, super supportive. So I spent many hours on the presentation based on Allison's book, but based on the first 3 chapters of the book. The initial plan was to make it about her book with some other research sprinkled in. And then I realized I'm only on chapter 2 and I already have an hour and a half lecture. So I stopped at the first 3 chapters. I keep telling myself I'm going to make a part 2 of that lecture with the other 3 chapters, but I haven't done that yet.
Yeah, and when you initially posted it, the comments were like, "Oh, okay, this is going to be like some like men bashing, man bashing session or whatever." And that was interesting because there's just this immediate opposition to it, right? They're like, "Oh, what is this? You're trying to hate on men," and that's not what it is. And EMS and physicians and people, they're scientifically minded, right? They should be thinking about the underlying physiology and the cells and stuff. But sometimes you can kind of fall into thinking that this is more of a political topic than something that's health related. And so you start reading this book. You've known Dr. McGregor for a while. It sounds like she was up in New Hampshire before. So you bought her book, you're reading through it, and you're reading certain parts of it. We're not ordering different lab tests and stuff typically in the back of an ambulance, but there is a lot of stuff we can take away from it, especially with what Dr. McGregor said with patterns, mental models, the things that we expect to see, what a chest pain patient looks like. And if they're not telling you an elephant sitting on their chest, you're thinking, well, maybe it is indigestion. Maybe this is anxiety. So when you go out and you teach this, because you've done this topic or you've done this lecture several times, what do you stress? What are like, give me like the top points that you really want them to walk away from when somebody goes, hey, how was Tim's talk? And they go, oh, it was really interesting. I learned that blah, blah, blah. What is that?
Right.
What do you want them to say?
So I have a couple of goals with this lecture, and one is for EMS providers to change their mindset. I don't know if it's necessarily their practice, but to change their mindset. I usually start off the class and just say, what would be the top 3 or 4 symptoms of a stroke? And of course, everybody names arm drift and speech and one-sided weakness. And I say, okay, and kind of give that a little teaser, or I talk about a case of someone with with a headache or some altered mental status that's a 59-year-old female, and everybody runs right down the UTI route and then turn it into how it's a stroke. And that sort of gets people thinking, oh, and then we get into the MI stuff, and I'll ask people, what kind of symptoms do women have when they're having a heart attack? And everybody says atypical. And I say, well, they're atypical for men, they're not atypical symptoms for women, right? We need to
Mhm.
change that mindset. A couple of the big things that I mentioned that immediately changed my practice, easy changes, is when you're looking at women with MI, or really kind of a lot of cardiovascular stuff, but particularly acute coronary syndromes, is we all know the normal risk factors we ask about: high cholesterol, diabetes. But with women, we need to ask and look at rheumatoid arthritis, and we need to look at um, early the early period, early menopause, and did they have preeclampsia and these other things, complications with pregnancy, even if they had their baby 25 years ago or something. And that right away I changed, and now I ask those things. If I have a patient with suspected ACS that's a woman, I ask the normal risk factors. I also ask those extra ones. So that's sort of the one of the quickest, easiest examples. But a big part of it is just being aware of this will reduce your bias, and you'll be more conscientious about saying, don't just ask about chest pain, don't just ask about facial droop, and then the chapter on pharmacology is what really opens people's minds. And some of the most common medications that are prescribed to our patients were never tested on women.
And Dr. McGregor, when you're coming in and assessing a patient in the ED, obviously the term pretest probability, right? Before you go and order the whole, kit and caboodle of labs and get D-dimers back and everything, you want to have a certain degree of, yeah, I think this is what it is, and I'm testing this to rule it out, as opposed to maybe ruling something in. When I have a chest pain patient, I was taught the same thing. Women have atypical symptoms. It may not be chest pain. It may be jaw pain, or it may be tingling in the jaw, stuff like that. But I'm typically still going to be doing a 12 lead and pursuing that, right? So if somebody were to take away from this that, yeah, maybe women have more vague symptoms, they're not the big elephant sitting on the patient's chest. If they were to do a 12 lead and they were to still go down that, and they say, hey, anything, if you have a pulse and a problem above the belly button, we probably need to do a 12 lead. Are there going to be things on the 12 lead that are different with women? I know we see in ACLS and stuff, they differentiate the millimeters of ST elevation, and as much as we're trying to get away from that and move to like OMI and stuff like that, if somebody didn't catch that right away, like let's say somebody had a headache or something like that, that may not trigger them to do a 12 lead. So my question is, should we just be, I don't know, like, if somebody came in with a headache, are you automatically ordering a 12 lead in the ER? Or if they're coming in with maybe some ear pain, like what does that look like in your day-to-day practice?
That's very interesting because it is challenging. No, we're not saying that this is easy because we have to unlearn lots of biases that we have, been trained to think of. So, when for us in the emergent, part of caring for patients, they are undifferentiated, right? So we are the diagnosticians. We have to sort of think about, and that's the hard part for us. So we have to put the whole picture into place. So if someone comes in with a headache, my differential might be very broad or it might be narrow depending on what they're sort of giving me. You have to be careful of thinking of the biases. Now, women still have STEMIs. They still have ST elevation MIs. They still have a large coronary artery that develops a blockage. But what we're learning is that the way that those coronary arteries in women develop plaque and develop blockages could be different. The way that women have heart attacks that are not blocked arteries, like microvascular disease, is not going to show up on a 12 lead. But it's still a heart attack, right? Women are more likely to have spontaneous coronary artery dissections. So these are the types of things that we haven't thought about because when we think of a heart attack, we think of an anatomical problem with an anatomical solution. And that is going to the cath lab. Oh, here's a STEMI, go to the cath lab, you put a stent in, you open it up, and it's done. And so because women have different types and different ways of having heart attacks, and because they have different types of risk factors in developing those differences, it's really remarkable. And so we have to sort of think of it in the entire spectrum of how this particular woman has disease. And I'll tell you that all of this matters. So, and it's not just about what to look for differently on the EKG. Think about all the delays that happen. So if we take a particular, a typical woman, say she's like 36, right? So we're taught that women don't have heart attacks until they're postmenopausal. This is false. So say she's 36 and she's been tired for the past, week, really just fatigued, can't really get her breath. She doesn't recognize this as a potential heart attack. So she goes to Trader Joe's and, she's like, they think I'm going to pass out. So she tries to get to her car. She passes out. She's less likely to receive bystander CPR. That's been proven because when we teach CPR, we teach it on a white male torso.
Yeah.
And,
Yeah.
with, no one wants to be, expose a woman's chest. That's one of the major reasons that we discovered why women don't receive standard CPR, So then EMS gets called and they come and she's waking up and she just says, I've been tired and short of breath. And they're not, lights and sirens. And what if she said, well, I feel better now? And they're like, oh, I guess you can go home too, So that delay. And then the triage nurse in the emergency department doesn't think to do an EKG right away and have it checked within 10 minutes. And then they're sitting in the back waiting 3 hours. And then that delay just gets, and maybe that doctor doesn't think to order a troponin or admit the patient. And then the cardiologist doesn't know. And this is why women are less likely to be diagnosed, less likely to be treated, and more likely to die when having a heart attack just compared to a male. So it's very, it's throughout the whole process that we have to really sort of create that awareness. And that's why I think this is so important for at least the pre-hospital knowledge base to understand that these differences are now becoming exponential. And we have to sort of bring that into our education and our knowledge base and our practice.
Yeah, it seems as, because these symptoms are more vague, if you were to take, let's just say, I am going through residency or something like that, and you were to say, hey, we're going to have 30 people come in, and we want to test how accurate you are at finding the ones that are having an MI. And I know that, right? And then I have a man comes in, he's like, oh my God, my chest hurts, he's diaphoretic. I'm like, okay, I'm obviously going to do one on him. It would inevitably lead to over testing on women because I don't know, it sounds like they could really present with anything. And so how do you prevent that from falling into this trap of saying, you know what, I don't want to miss it and feel like I'm biased towards this. So I'm going to run the whole panel. I'm going to get everything just to make sure that I am not missing anything. Do you want to do that? Do you want to avoid it? Like, what does that look like for you?
That's really part of the problem because if people think, oh, this is very vague, it's not a heart attack, so I'm not going to go down that road.
Hmm.
I'm going to give Maalox and lidocaine, and it's probably indigestion, or I'm going to give some Ativan first and see if that makes her feel better. And those things can make people feel better.
Oh yeah.
And it's not. So then it's like, say for instance, woman has microvascular disease or she has some other, Takotsubo's or something. So say she actually does go to the cath lab and then she's told that it's not her heart. Now she's going to the gastroenterologist and getting procedures, getting sedated. She's going to her psychiatrist and she's on all these medications, and then that can have some polypharmacy. So that is where we are at with women. We are not sure what to do. So we're
Yeah.
either over ordering, under ordering. They're going from specialist to specialist because they're not getting an answer. And then they're feeling like it's all in their head. This perpetuates the problem, really. So, it's about, awareness. It's about taking our current clinical decision rules. So for instance, we use the heart score in the emergency department to decide whether this patient can go home or should they be admitted. And that heart score is based on, biased data. It says how many risk factors does this patient have? But it doesn't include any of the female specific risk factors. And then it says, what's your suspicion of a heart attack? And that's like, well, my suspicion is based on how I was taught and educated. And so I think we're just at this impasse of needing to have this conversation, needing to have development of our educators so that they can really start to educate our people that are taking care of patients to bring this sort of new knowledge base in.
So when I am assessing a patient, let's just say on a regular basis, here's where my brain, my mental model, and this is where I want to kind of run this by you guys, has differentiated between male and female, right? So calculating ideal body weight, the size of their actual lungs when I'm coming up with vent settings. Men start off at 50 kilos if they're 5 feet tall. If a woman's 5 feet tall, she starts off at 45.5. So we're talking not a huge difference there, right? So that's one. The other one is, like we mentioned, the chest pain. We don't typically feel pain from within our vessels. So when that does happen, everybody's got a different way. Even men can have different ways of describing what that feels like. So that's the other. And then I really just, as far as meds go, I look at the lipophilicity profile of a medication. Is it lipophilic, and what does their BMI look like? Because I know that volume and distribution is going to be a little different with things like fentanyl, for example. And besides like OB/GYN emergencies and stuff like that, like the obvious, where you're not trying to differentiate, that's really the extent of it. And maybe some of the stuff you've mentioned on strokes. Is there anything that huge thing that I'm missing that somebody listening to this is like, yeah, that's really where I've been taught to differentiate it? Is there anything that I could add to that to increase my sensitivity to picking up on things?
So specifically related to drug metabolism and drug dosing, there is an incredible amount of evidence now that shows just how remarkable the differences in pharmacokinetics and dynamics are between males and females. The problem is that's not translating to our apps. I use Hippocrates to look up drug dosing. And there is only one FDA drug that has sex-specific dosing, and that's Ambien. And that's related to the fact that there were so many adverse events when the same dose was given to that was tested on in men was given to women. And so that's one medication out of 20,000 prescription drugs that are approved today. So there is a gap in translating what we are now discovering in a research scientific way to the actual clinical practice of caring for patients. So if you're thinking of the lipophilicity, especially if something like propofol, that I find that literature to be really, really remarkable. Women have higher body fat content. So if you have a drug that's lipophilic, it distributes more quickly throughout, but then stays there. And then and then it could have a prolonged effect. You're ahead of the game. What we need to do is really go back to clinical practice guidelines, start to include these things into, what we are referencing when we are caring for patients. So bravo to you. But we're at that gap of research knowledge. How do we then get it to clinical practice? We have to traverse the educational front first. And how do we do that? We have to educate our educators. So, that's sort of, if we were to take a temperature right now, that's what I would say where we are.
The other thing I forgot I was thinking of when you just said that is, a woman who's on birth control who just got back from, traveling or something like that, and you're like, oh, that's the story for a PE, and like that can be a risk factor as well. But Tim, what else should I be thinking of? Is there anything else out there that you teach? People ask questions. And obviously there is a lot, right? Like Dr. McGregor said, this is a long road ahead of doing this research and now going, hey, you know what? Like this is half the population. We probably need to look into this. So I don't want to make it sound like, is there anything else? But just in the immediate, we could lay out a million things, but what you're thinking of when you go out on a 911 call.
So I think when I go out on a call, even if it's like an interfacility transfer, and
A
I
job?
have
Isn't that what they call it there when you go on a job?
no, that's more in New York. We call
Oh,
it a call. Don't mix up New York and Boston. But yeah, so when I probably do now 60% of my shifts are transfer because my whole career I didn't do transfers. I just did 911. And so with both of those, I'll look at things like, is this drug, um, is this drug going to work the same on males as females? And if I have a 1 hour trip into Boston, is that going to affect this female patient the same or worse or not? Symptomology. Also, looking at things like, besides the sort of cardiovascular stuff, endometriosis, and it takes an average of about 7 years for a female to be correctly diagnosed. Interestingly, when almost about every fourth time I do this class, a woman in class will raise her hand and say, it took me 9 years and 11 doctors before I got my diagnosis of endometriosis. And so irritable bowel syndrome, there's data about that with men getting more x-rays and women getting more sedatives. And so I think the sort of big idea for me when I'm doing this class is keep an open mind with males versus females. But also the second part of this class to me is, so I have four, if you will, generations of women in my life, right? My mother's still alive. She's 85. My wife, my daughter, my granddaughter, who's 5, and everybody has wives, aunts, sisters, friends that are women, and we need to get that info to them so that they know when they go in to see a doctor. And something that Alyson once said or says in the book is a great line for women if a doctor diagnoses them with something is, what criteria are you basing this diagnosis on? If a doctor can answer that and know criteria and data and whatever, great. If they seem to be fumbling a little bit, then maybe it's not, maybe it's just more of a feeling than data behind that diagnosis, right? And just being, we obviously all try to be hopefully the best advocates for our patient, speaking up maybe a little bit if you feel the patient's getting the blow off a little bit in the ER. And EMS providers can only do so much of that, obviously, but also empowering and educating our women in our lives to know more of this stuff. Even if my wife's not medical, she's in investing, but making sure she knows a little bit of this stuff. So when she goes to the doc or gets a diagnosis, those are the sort of the big things, and just pointing out to folks like one of the things is that when a drug comes out, and maybe there might have been nowadays 30% of women in that study, even though they're 50% of the population, when they make generic drugs, the FDA, most drug companies almost exclusively test generic drugs on men. So now you're getting the generic version of the drug almost exclusively by that drug company. It's studied on men, and the FDA allows a 20% what I call fudge factor. So the doses, side effects, everything else can be off as much as 20%, and the FDA will still approve that generic drug. And so a lot of generics are not tested on women.
Dr. McGregor, you had mentioned in one of the interviews or videos I saw that men will take a baby dose aspirin every day in order to try to prevent having an MI, right, or having coronary artery disease. And you said women doing that is actually harmful. Could you elaborate on that? And does that apply to if I think they're having an MI, but I'm not sure because the symptoms are, jaw pain or something like that, and I give them aspirin? It's not like they can never take aspirin. Is that more over a long term of taking it every day?
Yeah, and that's the difference between primary prevention and secondary prevention. So if you've had a heart attack, then yes, you should be taking aspirin every day to prevent a secondary event. Or, of course, if you think someone's having potentially having a heart attack, you give them aspirin no matter if this is the first time or the second time. So continue that practice. It's really looking at those women that are taking it because they want to prevent having a heart attack. When they had those studies, as I mentioned, they were mostly done in men. And then you tease out what really I try to tell people is you have to have enough women and enough men in a study to analyze the data separately. So sex aggregated data. So it's not just like combining 50 men and 50 women and then seeing how they are with, and averaging it out, because they might have different responses, and then the result is going to average out. And so that's what happened. If you throw a few women in a study and they just get swept in statistically, once they looked at that, they realized actually the women who were taking aspirin to prevent a heart attack were also more likely to have GI bleeding, and they were having ulcers. And so that's always about benefit risk. The males benefited. This was the earlier studies that's even been questioned now, but it's that sort of benefit risk. So when you look at the women coming out, and I want to just make a comment about how important this is for males as well. And I really, found that COVID became a good, advocate for that, because males were more likely to die than females with having COVID. Males are more likely to be in the ICU than females when having COVID. When the incidence of getting COVID was about the same, the males did worse. And so that really sort of looked at what's the pathophysiology going on there. And it's remarkable because things like androgen and testosterone in the lungs, the receptors that you have of that in the lungs, made that virus absorbed, quicker and affects the way that, males sort of, heal or don't heal. Women have higher immune responses. That's why we have autoimmune conditions, which means males don't have high immune responses, which means they're more likely to get sick if they get something like COVID. So this is really about just a greater, deeper understanding of the differences between males and females so that we can both tailor, and have precision medicine as our future. So we have some catching up to do with understanding women's bodies, but this really is just about the science of understanding the differences in these two remarkably, I like to say almost different species.
Yeah. Do you feel like since 2007, when you started digging into this, that we've seen pretty drastic increases in the awareness to this? Do you see certain medications now coming out that are looking and aggregating that data closely between male and female, or do you feel like we're exactly where we are when you first started looking into this?
We are not exactly where we are. We are really climbing into the future because you can't unknow this. This is science. And so where I think we are is the NIH put a requirement in grant funding that you must include sex in the design of your study. So you have to say that you're going to include both sexes and analyze it separately in some way. Since that has happened, we have just just expanded the amount of information. It's really, really remarkable. There's these PubMed search tools that I use regularly while I'm on shift that will comb the literature to look for sex or gender differences in asthma, in toenail pain, in earaches, whatever it is that you want. And the amount of evidence is really, really exponential. The problem or the next challenge is we have all this information now from a scientific research perspective. We have to sort of now fit it into the practice of medicine. So but no, I think this isn't going anywhere because if you stick with the science, this is really fascinating and critical, and you can't just say it doesn't matter anymore.
Yeah, and we've talked a lot about the diagnostics, and we dabbled on some of the pharmacology, but just to I don't know, say put your feet to the fire a little bit. Like if you have a patient who comes in, and let's say it's a female, and she has a femur fracture, some sort of pain that you can tie a direct cause to, right? It's not like some vague pain. Is there a certain medication that you're like, oh, I'm going to avoid that in this population because it can cause more complications, or does that really not matter? I'm specifically talking pain medications at this point.
No, it completely matters because we know that opiates are more likely to provide shortness of breath. So they're more likely to decrease the oxygen saturation in women and cause respiratory depression.
Gotcha.
So that's big. It also causes more vomiting. So that's important. And the other thing that's really been shown over and over again is that even if it's a femur fracture, you have a patient that's a male with a femur fracture, and right next door it's a female with a femur fracture. The female probably is showing signs of anxiety, right? Because that's what, culturally women can show anxiousness, and that's how we express, our concern and pain. And so women are much more likely to be given benzodiazepines for pain than men. So they're given, some Ativan, some Valium, and now they're a little bit loopy, but they're still in tons of pain. So then you're like, okay, here's morphine, here's Dilaudid, and then now they need oxygen, and it starts the polypharmacy thing. So where men, it's like, oh, you have a femur fracture. Here's some Dilaudid, here's some morphine, here's some fentanyl. It's much more streamlined. Women are definitely overprescribed, overgiven, and are much more likely to be given anxiolytics than something truly for pain.
So they're likely to go, all right, let's try to calm her down first, and then we'll address the pain, and then that's where you start giving benzos, and then you give them fentanyl, and then you give them stuff like that.
So when I'm teaching, I say that yes, this woman's anxious, but maybe she's anxious because it really hurts.
Yeah. I think that's probably why they give me benzos in the ED too. But
I think also the the QT prolongation, women have longer QTs normally than men do. So
well, that's interesting.
if you have somebody that either maybe is in a dysrhythmia and we want to look at, okay, these are the meds you're on something for your rheumatoid arthritis, but what about, oh, you just got started on antibiotics 2 days ago, right? And those two together can cause prolonged QT because women have a longer QT than men anyway, right? So, or certainly for prescribing practitioners is realizing that you don't want to be mixing up drugs that can cause issues, right?
Zofran,
So
for example, like, is that a concern? Because we know that can prolong the QT.
That I think that Tim, that's a perfect thing to bring up because if we think about the QT interval, before puberty, boys and girls have the same QT interval. And then testosterone upregulates potassium channels in the heart, which
Oh
causes
wow.
a quicker repolarization and a shorter QT interval. So while testosterone is pretty much maintained throughout life, there's a protective effect. Now, each medication, it's like I say, like, which medications prolong QT interval, and there's so many. It's
Hmm.
probably easier to say the ones that don't, right? So then, if women are more likely to be prescribed medication because they're not diagnosed or misdiagnosed, or maybe it's GERD, maybe it's anxiety. Here's a SSRI. Here's this, and then you give them an antibiotic, and then it just goes longer, 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 and then they can go into torsades or fetal arrhythmias. So yes, that is a critical piece to keep in mind. I'm glad you brought that up, Tim.
And Tim, I kind of cut you off. Was there anything else you were going to finish off with that?
uh, not with the QT part. Um, yeah, we can talk sort of about what we can do in the future to sort of help EMS with this towards the end. But yeah, I just wanted to bring up as we were talking about meds, the QT prolongation thing, because women have an average of about what 470 Allison, and men are about 450. So that can potentially cause issues.
No, and that's the stuff I love, the nitty gritty details like that, and then the testosterone upregulating potassium receptor, like that's the stuff I'm like, okay, there's the stuff I want. I want to take
Yeah,
some of that with me
yeah.
because I'll remember that. So, all right, so we've been talking for about 45 minutes now. We'll start kind of rounding it up a little bit. What's the message that people should take home that we haven't already talked about? We obviously know there's a bias. If you guys want to learn more about that, highly recommend reading Dr. McGregor's book. It's called Sex Matters. I'm guessing you can get it on Amazon, or probably do you have a website or something they can get it from as well?
Yes.
Okay, so we'll put some of that in the show notes. So EMS providers are listening. They're going, wow, that was interesting. I wanna try to apply that. Maybe thinking about the benzos and the analgesics, and thinking about the QT and the Zofran. Is there anything else? What questions am I not asking you? Or what should we leave people with before we head out? And I'll start off with you, Tim, and then we'll end it with Dr. McGregor.
Sure. So I think the biggest thing is being aware, and if people are taking the time to listen to this podcast, maybe reading an article. The book is also available on Audible. So if you're like me and you don't know how to read, it's on Audible. And I think being aware of this to keeping your will keep your mind open because as Allison said, you can't sort of unlearn this stuff. For me, I think going forward EMS wise, I think we this needs to be added, whether it's 2 pages or 3 pages or a chapter. People need to start learning this in their initial program. Because as you know, Tyler, like what people learn in their initial programs, they tend to stick more deeply with and hold on to, even though they're learning newer stuff. Some people don't want to give up what they learned in medic school or EMT school. So I think in the initial level, this stuff needs to be in the textbooks. And as Allison said, sort of educating educators. I did this class. The last conference I did it at was Texas in November, and and the front row had four different, conference presenters and educators that were sitting through it. And I think that's what we need, is because if educators keep teaching the wrong stuff, people keep learning the wrong stuff.
No, excellently said. Dr. McGregor?
Yeah, I think, I'm just so thankful that Tim has, brought this into the, the pre-hospital education space. I think people should just understand that if you're in medicine and health, it's very humbling, because it evolves. And so that's okay. We're evolving along with it. And I would say to your audience, wherever you have a sphere of influence. So if you, think critically about your protocols, look at them to see, hey, maybe this is outdated. Or if you're in a journal club and you're talking about a paper, hey, did they include women? Did they analyze it separately? And again, just to consider the fact that this is really important for both males and females. Just be on the lookout, because more and more is coming. Thank you so much for allowing us to use your forum to spread this message.
Yeah, no, I really appreciate the time. And I'm going to build my own presentation and make the animations way better than Tim's, and then go out there and present it at all the conference. No,
I have a lot of in this presentation, I have a lot of AI images. But yeah, it's thank you, Tyler, because you have a big sphere of influence. And so I think a lot of people will hear this. And even if 5% of them say, I want to pick up a book or listen to a podcast or read an article. I mean, Outside Magazine, who would have thought, wrote an article about this, a few years ago. So I think you're helping to spread the word, and whatever people need me to do to help out, whether it's at a conference or a local class over Zoom or whatever, just let me know.
Yeah,
Thanks for having us.
Are you giving this talk anywhere soon or this year?
So far this year, I am doing it in North Carolina, which is in May. I'm doing it that same week in. Actually, I'm not doing it in Lake Placid, and probably most likely in Alaska in November. And I'm still waiting to hear from, all the fall conferences most of them haven't sent out their acceptance letters. But what I find really interesting is that since I've been submitting this class for conferences, it's been chosen at almost every conference I have. So conference presenters, sort of see the need, or maybe just because it's different and unique. But typically, most conference I've submitted, and I always include this class, that particular class gets chosen, which is great.
What's the best way for people to find out where you're going to be presenting these? Do you have a website that people can go to and see it, or is it just follow you on Facebook or social media?
Yeah, Facebook, and I do have a website, eecmedical.org. I need to sort of update when I'm going to be at conferences. Right now, I know I've been accepted for 3 so far this year. Still waiting to hear from another, probably 7 or 8. Facebook, Tim Redding. My business has a Facebook page, but I really utilize sort of my personal page for a lot of this stuff because I follow and are friends with a lot of EMS people. And then you can email me at tredding@EEC Echo Charlie medical.org, and let me know if you need any help with this stuff, because we need to spread the message.
Awesome. Thank you so much. Thank you guys both. And Alyson, if you're cool with it, are you cool with me putting your email in the show notes as well? If anybody has any questions to reach out.
Sure. I'm always.
And I got your personal cell phone too. I'll put that on there.
That's cool.
And then the last four of your social.
It's my address.
Yeah, absolutely.
All right. Thanks, guys.
Thank you.